My name is Jenny Kringle. Today we're going to talk about deep vein thrombosis. We're going to go over the definition of deep vein thrombosis. I will introduce a case study, go over additional information, conclude, and show references. So what is deep vein thrombosis? Deep vein thrombosis, or DVT, occurs when there's thrombus at any level of a vein, but is most commonly found in the lower extremity deep veins below the knee. Over 2 million people are affected by DVT annually, with a mortality rate of over 200,000 due to complications such as a pulmonary embolism. And about 74% of Americans are unaware of what DVT is and how to prevent or treat it. The case study I researched is on a 13-year-old male who presented with left leg pain and edema, shortness of breath, and a high-grade fever. Other possible diagnoses for the left leg pain include arterial disease and cellulitis. Other diagnoses for the swelling include CHF, kidney failure, a Baker cyst, or injury such as an ACL tear or a broken leg. All are unlikely, though, due to the patient's age. He has a history of pneumonia and seizures 3 weeks prior to hospitalization. The patient's risk factors are familial. His mother had a history of a pulmonary embolism, and his father has factor V Leiden mutation. According to White, 40 to 50% of hereditary thrombotic events are due to factor V Leiden. Other common risk factors for developing DVT include advanced age, cancer, or minor injury, or a reason for immobility. The diagnoses that the patient has: he was positive for DVT by a venous sonogram. He was tested positive for a pulmonary embolism, which was shown by computerized tomography or a CT scan. And based on the lab work, he was tested positive for factor V Leiden mutation, lupus anticoagulant, prothrombin mutation, and antithrombin 3 antibody. The diagnostic testing that the patient underwent includes a lower extremity venous sonogram, a CT scan, and lab work for clotting tendency testing and INR assessment. The patient was hospitalized for 10 days because he could not get discharged until his INR was between 2 and 3, and it stayed below 2 for nearly 2 weeks even while on anticoagulation therapy. Other testing to diagnose DVT includes a D-dimer, which measures high levels of fibrin fragments to indicate thrombus or lysis formation, clotting tendency testing, a lower extremity venous sonogram, CT scan, a venogram, or a VQ scan. Here's an image of the right common femoral vein. It shows blood flow around the DVT, and it shows severe reflux during the patient's hospitalization. This is an image of the right femoral vein at mid-thigh. It shows a subacute thrombus right here, and we know it's subacute because the vein is no longer as dilated. And if it was acute, it would be less echogenic than if it was chronic or subacute. This is an image of the right popliteal vein during hospitalization, which shows acute thrombus. We know it's acute because the vein is dilated and it was non-compressible. The treatment plan during hospitalization includes anticoagulation therapy, such as heparin IV and warfarin, pain meds for his leg pain due to the DVT, zithromax and biaxin for a bacterial infection, and compression stockings. After the discharge, the patient was on Eliquis, compression stockings permanently, and received routine follow-up visits to rule out acute DVT. Here's an image that I scanned on October 2015 that shows little to no blood flow in the right common femoral vein. The collaterals are working and there is not yet recanalized flow. Another image from that day is of the left popliteal vein. Here we can see subacute thrombus in the vein. It is dilated, but not as dilated as it would be if it was acute, and the thrombus is more echogenic than if it was acute. Another picture of the left popliteal vein shows recanalized blood flow, as well as severe reflux due to the damaged valves from the deep vein thrombosis. The research objectives over DVT include the pathogenesis, effects, pathological progression, treatment options, and prognosis. The pathogenesis is mostly genetic. According to the National Blood Clot Alliance, the passing of DVT genetically is called dominant inheritance, and there is a higher chance of DVT formation if more than one familial gene carries it. Other options are idiopathic, seen in pediatrics, stasis or clotting disorders, and it is most commonly found in the African American population, and Asian and Hispanic populations are least common. The effects, there's macro and micro effects. The macro effects include harm to the lungs and the respiratory system caused by the PE. The whole respiratory system can be affected due to the compromised pathway from the pulmonary embolism. Here we see an image of a saddle PE compromising blood flow to both lungs. Some micro effects are at the cellular level. We see a formation of clot disorders such as factor 2 and factor 5. We see an increase in transferrin, which is an iron-binding blood plasma glycoprotein, as well as platelet reactivity and fibrinogen. The progression varies depending on the patient, their risk factors, and the treatment. It depends on the location. It is most commonly found in the lower extremities, especially below the knee, but can also occur in the upper extremities. And it can occur in any vein. It is known as deep vein thrombosis when it is in a deep vein, and it is called superficial thrombophlebitis when found in a superficial vein. It is more severe the more proximal and if it is mobile. Really, we don't worry about a chronic DVT because it has not yet attached to the vein wall. Acute DVT can lead to a PE if it is mobile. Treatment options include pharmacological, which is anticoagulation therapy, such as Coumadin, Lovenox, Xarelto, heparin, and Eliquis. You can use vitamin K and pain medications. Other treatment options are mechanical, such as compression stockings. And with the dilation of superficial veins, the compression stockings help support the vein by adding extra pressure, according to Johnson. Some procedural options include an IVC filter, which are placed in patients who have frequent thrombi and have sought out anticoagulation therapy but still develop a DVT. And there's also an option of a trellis device, which is a procedure to remove thrombus by inserting a catheter into the vein and blowing up a balloon on both sides of the clot. After 10 minutes, the clot-busting medication is given to dissolve the thrombus. Treatment options depend on the severity of thrombus, whether it's acute or chronic, if it's proximal or distal, how many vessels are affected, and if it is mobile. The role of sonography is major in the diagnosis of DVT. Venous ultrasonography is accepted as the primary role in non-invasive testing in the diagnosis of acute DVT, according to Johnson. We use grayscale imaging to show compression. In a vein with thrombus, it won't compress. We also use grayscale imaging to identify between acute and chronic by the echogenicity and the size of the vein. Color Doppler is used to show obstructed flow or recanalized blood flow. We also use spectral Doppler to show continuous flow. Continuous flow will indicate a proximal obstruction due to the DVT. We can also assess reflux, which would be caused by a damaged valve from the DVT. Expected outcomes vary upon treatment. With treatment, you have the development of subacute or chronic DVT, but it could dissolve altogether. We usually see severe reflux, and the likeliness of future DVT or PE is low when the patient is on anticoagulation. Without treatment, it may be fatal. It could be a pulmonary embolism, which could cause a fatality, and you could see severe reflux due to the damaged valves, which is usually untreatable. Here we have the signs and symptoms, such as the edema, fever, and left leg pain. Because of those symptoms, the patient received a lower venous duplex. With the lower venous duplex, we saw positive acute DVT. With the acute DVT and pulmonary embolism, the patient was hospitalized for 8 days. Upon hospitalization, the patient sought out treatment. Treatment included the anticoagulation therapy, compression stockings, and the pain meds. Due to the anticoagulation therapy, the patient received lab work, such as INR testing. The INR was 1.9 on the first day and went to 3.2 on the last day. With the INR being 3.2, the patient was discharged, had follow-up sonograms, which showed the positive chronic DVT. So in conclusion, 74% of Americans are uninformed about DVT. It can be manageable, and it can lead to a good prognosis, such as the patient from the case study. So be aware of the symptoms, such as the sudden leg pain and edema, and contact your physician if you suspect a DVT, and use the proper treatments and plan to manage it. Here are the references I used during the presentation. Thank you. Have a good day.